Welcome into another edition of BR Ortho Talk. Pleasure to have you with us, and pleasure today to be joined by a guy who I have had the fortune and misfortune of seeing in clinic, Dr. Brad Culotta. He is a pediatric orthopedic surgeon. Great to have you. How are you?
Thanks for the opportunity. Appreciate you hosting.
Of course. One of the cool things, we've always gotten this opportunity to get to know the doctors a little bit. Known you for a long
Go
time.
way back, as they say.
Let's kind of start a little bit with somewhat of the origin story. You're from Baton Rouge. Kind of pick us up. If I give me the Cliff's Notes life version of Brad to this point.
I was born and raised here. Kind of a, I guess, traditional story, so to speak, in the sense that I had two good parents, an older sister. Grew up here. Went away for training, but came back. And growing up, my dad was in sales and traveled a lot. He was good at what he did, taking care of people in his business. My mom was kind of the homemaker. She made sure home was comfortable and they were supportive in whatever we did. My sister and I argued a lot early and then later got along and loved each other. And so Baton Rouge was my upbringing. I always thought early on, I had sports aspirations. Oh, I love sports. I want to play sports when I get older, and that's what I'm going to do. And it was pretty soon in high school I realized sports weren't going to carry me into a career path. So it came pretty apparent that the books and the studies and then developing relationships were going to be my ticket to success. So kind of the hard and soft skills. So that's when I kind of dove towards the pre-medical or pre-professional route.
Mm-hmm.
When I finished high school, I thought, I really like dentistry. I want to do something. My orthodontist was good at what he did. He took good care of me. He took care of patients and families, kids and families, and he was successful and enjoyed what he did. I said, I want to do that. And then in college is when I got some experience in the medical field. I said, medical over dentistry is better for me. And it kind of evolved from there into orthopedics and kids and beyond.
So there wasn't always a drive to do orthopedics. Like there wasn't because so often, especially whenever you mention sports, wanting to play sports, we hear this a lot from you probably hear it a lot more than I do, but
yeah,
there was a sports injury maybe as a kid and realized, that's really cool, I want to do that. You never had something like that piqued your interest when you were young?
I agree. That's a common path. That was not me. I early on, after the dental or orthodontic route, I thought I wanted to do something in the service profession. I really liked taking care of people, serving people, and I didn't know what aspect I wanted to pursue. So after I got some experience kind of volunteering, working in medical field, I thought, okay, well, medicine over dentistry is my path. And, in medical school, first couple of years is mostly, classroom based, but the last half of medical school is clinical based where you get some rotations and experience. So I really liked cardiology, and I worked some in cardiology as on the side. And, I thought, man, I love that. And I was kind of one of those that go through all the rotations, and I kind of liked everything. But I really liked cardiology. And then I did an elective rotation orthopedics. I said, I love that. And I remember one of the staff members said, well, you need to decide whether you want to carry a stethoscope or a hammer. And so I did more rotations in each of those, and that's when I loved orthopedics. The anatomy, the biomechanics, and then you combine carpentry and engineering, and you get to put stuff back together. You get to fix stuff, and I like the variety. I like the clinic, but also procedures and surgeries, and so that's what really drew me to orthopedics.
You went to LSU undergrad?
I did. I was here in Baton Rouge for undergrad, and at the time that was when top scholarships were a big thing, and I really was excited to go to LSU and be with a lot of friends that I had made through high school at other high schools and get to part of the the fun scene, but also, the pre-med scene. Made a lot of friends through that, and pre-dental that, friends were going through the same classes. And so I went to LSU here, and then right down the road, LSU New Orleans for medical school.
So when you finished med school in New Orleans, that's generally the path where now you're finding out what your path is going to be, and you went away. Where did that path lead you?
Yeah, at the end of medical school or near it, you're kind of saying, okay, what do I want to be when I grow up, really? A lot of your friends have already been working for 5-10 years, and they go, oh, you're still in school. So yeah, you're still in school. And so you're trying to figure out what I want to be when I grow up. And that's when I chose orthopedics. And so you go into a match where you try to rotate at different places, see who likes you and who you like, and then they match you up. And that match, I really liked University of Alabama-Birmingham, UAB. And no, I still bleed purple and gold. I'm not a Crimson fan, but it's interesting. In Alabama, very similar to here, the medical schools in Birmingham, the undergrads in Tuscaloosa. So here, the medical schools in New Orleans, in Shreveport, the undergrads in Baton Rouge. And so I matched at UAB in Birmingham, and that was really strong for orthopedic surgery, which I was really excited about. And they got a good variety, good exposure, a lot of different aspects of orthopedics. And so that was, 5 years in Birmingham, which was a great city, really enjoyed it. The people there, a lot of SEC graduates that were there for, secondary education. So that made it a lot of fun, and a lot of bickering with different fans of different fan bases,
That's how it tends to go.
Exactly.
In Birmingham and Atlanta, the two big sort of metropolitan hubs in the South.
A lot of LSU folks. Yeah.
You get a lot of SEC fans there. How did being from Baton Rouge, going to LSU, and then going away, it's always interesting to hear the story of what draws people back to Baton Rouge. So what drew you back here?
Yeah, after 5 years in Birmingham, I said, you know what, I really love taking care of kids. I want to do kids orthopedics. So I spent another year in Atlanta just taking care of kids and learning all the intricacies of that as it relates to orthopedics. And it was at that time, during that year in fellowship in Atlanta, where you sort of say, okay, where are we going to land and start a family and raise our kids? And my wife and I, we got married fourth year of residency. So we said, okay, we definitely want to be in the South. We like like warmer weather. And she definitely doesn't like colder weather. Yeah. So we said, all right, we want to be in the South. And we interviewed across the Southeast, because that was we were going to be close to family. We were going to be, in a decent sized city, because for kids orthopedics, you typically are in a city that's a size that would, support a specialty like that. And usually you'd be associated with a children's hospital. Interestingly, here in Baton Rouge, for about 20, 30 years, they had been talking about building a freestanding children's hospital, and we did not have one. And the city was a size that could support one, and the complexity and breadth of medical care that could support one, but we didn't have one. So I connected, and I credit Brian Griffith, who, I would say is kind of a patriarch of our group, a godfather of our group, Baton Rouge Orthopedic, who I connected with, and he and I had several discussions, and he said, look, for years I've been looking for a pediatric orthopedist. We've not had one in Baton Rouge Ortho. We've not really found the right fit. I think it was kind of an under-recognized specialty here in Baton Rouge, the idea that parents understand that there's somebody that's spent their entire training just to take care of the child with an orthopedic problem. And so there was a need here, and family was here. And so that made a perfect match for us. And that's what brought us back. And I never looked back. 10 years now.
I mentioned when we started that I had both the fortune and misfortune of being in your rooms. My son had as so many parents do. My son had a broken arm. Playground, kid ran him over. It was accidental, but he falls and breaks his arm. How I find it fascinating with orthopedics, because and we'll get into some of the sort of specific things that you deal with, but you also kind of have to be a dad in there as well, in a sense, like, because, kid goes to the doctor. It's not like an adult, which is always just going to be obedient. Open your mouth, lift your arm, right? So how did that challenge sort of evolve, or is that always sort of a challenge?
It's funny now. The way I catch up with a lot of people is because their kids get hurt, and I say, "Oh my gosh, I haven't seen you in forever. How have you been?" And so we catch up because now I have young kids and they have young kids, and so we connect on that level. I think it's helpful as a parent to be able to empathize and see it through their eyes. And pediatrics is fun and rewarding, but it's not always butterflies and rainbows taking care of kids. So to your point, it can be challenging, and that for several reasons. That a lot of people say you're dealing with 3 patients instead of 1, the child and their 2 parents. And so challenging dads like yourself can be, hard to manage.
That is a lie.
It's a lie. And, probably a third of my patients can't communicate effectively with me. So, because I take care of birth to age 18, so probably age birth to 5 or 6, not going to be effective as far as asking them a lot of questions in detail. And then there's a whole host of special needs kids that have a hard time communicating. And so, I think pediatrics is a thinking man's specialty in the sense that you have to be a keen investigator. If you try to ask a 2-year-old, well, where does it hurt? When did it start? What makes it better? What makes it worse? Is it the right or left side? Good luck with that. That's not going to help you. So in some sense, it's sort of analogous to veterinary medicine, a vet for small humans sometimes, and trying to figure out. And then you have to have patience. At any given time in clinic, there could be random screaming and crying and peeing and pooing, and if you get flustered by that, it's probably not your cup of tea. But in that same vein, what a rewarding opportunity and honor and privilege when somebody says, what, I entrust the care of my child to you. And I think that's pretty special. So an honor, but a challenge and a responsibility.
Let's talk about some of those responsibilities that you see somewhat commonly. Scoliosis in kids is something that I know you deal with. I feel like I know what scoliosis is, right? It's a curvature of the spine.
Yep.
What causes that?
Well, you're right. Scoliosis is a curve of the spine. It's a 3-dimensional twisting of the spine. It's typically the most common type we treat and is otherwise perfectly healthy kids. So there's nothing they did or didn't do to cause it. It can run in families, but doesn't have to. It's really, if you think of the building blocks of the spine stacked on top of each other, they all have growth plates, and you basically get asymmetric growth. One side grows faster than the other, so it causes a curve. And not all curves need treatment, but they typically are picked up either in the school system with a school screening or a sports physical, or it might be a mom that notices her daughter in a bathing suit, something's, shoulder asymmetry, waist crease asymmetry. It could be a dance teacher, a ballet teacher, a sports coach that notices something where they're shifted or off. So it's a pretty common condition we see and follow and sometimes need treatment.
Is it something that you'll see at birth, or is it normally something that doesn't present or develop until later?
So really both. The more common develops in the preteen growth spurt. So as you hit that rapid growth spurt is when that asymmetric growth can occur. So that's the most common. But you can be born with building blocks that aren't perfect squares. So if you have square, 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 triangle thrown in the mix, square, square, that gives you a curve that's present at birth. And that's called congenital scoliosis if you're born with it. And then some of the squares don't perfectly separate. So if there's normal disc spaces between the blocks of bone, that's common, but normal. But if you have a disc space that doesn't form or forms on one side, that can cause a curve or a tilt. So it can be present at birth, and those create a challenge in terms of treatment. Because imagine scoliosis generally worsens as you grow. And so think about the growth remaining in an infant. They got a ton of growth remaining. So therein lies the challenge.
I don't want to make parents worry like, oh my God, it's something else I have to think about or worry about. But are there things that you would tell a parent at a certain age, point of the development, where you'd say, okay, well, this is something to be on the lookout for, or is there a point where it's sort of critical to identify issues?
Well, as it relates to scoliosis, generally the peak alert time is during rapid growth phases. We grow fastest in the first 5 years of life, and then during our preteen growth spurt. So most of the diagnoses for scoliosis come in that preteen growth spurt. So for girls, they grow fastest generally between the ages of 11 and 13, and for boys, it's a little bit later, 13, 15, somewhere in there. And some bloom early, some bloom late, but that's generally when schools that do screenings. That's generally when pediatricians have a keen sense at your child's well visit about looking and screening, but they're getting looked at in the early years too, generally at pediatrician well visits and such. So I don't think there's any reason to worry or panic, especially in the early years, because it's pretty uncommon, but usually is something that's caught to medical attention. And in the later years, the preteen years, is where screening can be really effective.
And when you talk about screening, something that I can remember, I'm sure most people, you as well, would be like before a sports season. If you were going to play basketball or football, you'd go through whatever, even at a young age. Sports injuries, I would imagine, in young people would be a large portion of what you correct me if I'm wrong, but it seems like that's something that would be very common when active young people get injured playing a sport.
Absolutely. If you look at the numbers of kids involved in sports, especially at an early age now, it's gone way up. And especially the number of kids in competitive sports. So interestingly, a lot of the injuries that we used to see and manage a lot more commonly in the teenagers are presenting now in preteens and even before that. Things like ACL injuries, things like kneecap dislocations, meniscus tears, overuse injuries of the elbow or the shoulder in throwing athletes. So, I think sports is awesome, and it allows for teamwork, camaraderie, discipline, responsibility. But in that same vein, there's the challenge is if you do a lot of something, we see a lot of overuse injuries, and it's repetitive demand on the immature skeleton and the immature growth centers that usually cause pain or irritation. A lot of them don't need surgery, but some of them have to be backed off from their number of hours per sport. It's usually a volume issue, not always, but too many miles, too many throws, too many tumbles, too many fill in the blank, whatever the activity becomes usually the culprit.
I want to come back to the overuse.
Yeah.
But on something you said there, with your ACL, meniscus, I would normally think that in young patients you deal with breaks more commonly. It feels like you tear your ACL, it's an older person's injury.
Yep.
How young do you see ACLs, meniscus tear, things like that?
Well, I think we're seeing it in younger kids now than we used to. I think I've got I can think of a handful of maybe between 6 and 8 year olds that have torn ACLs, which is uncommon, but it happens.
Doing what? Doing sports?
It might be sports. It might be jumping off of something and landing. It might be riding a dirt bike. It might be a trampoline park. But
did you jump off of trampolines as a kid? We did that, which now in hindsight feels really unsafe. Like we would bounce to jump off the trampoline onto the ground.
They sound a lot of fun, but they are usually the problem is you get big kid, small kid, and so then the mismatch in size, and of course the double bounce is fun, but it doesn't end well.
How did we ever have trampolines without nets around them? Like, how is that ever a thing?
I agree.
Yeah.
You know, in the age of and three-wheelers and those types of things. So in terms of young sports injuries, we are seeing more injuries that may need management or treatment. And so our field in pediatric orthopedics has had to evolve to that to manage growth respecting procedures. And what I mean by that is really, if you ask me, the main differentiator between me and the adult orthopedist, it's the presence of the growth plate and how to respect and manage and care for that as it relates to injuries and problems in kids orthopedics. So for example, for ACL injury, if you are young and have a lot of growth remaining, you tear your ACL. The old thought used to be just wear a brace till you're done growing, and then you'll have it fixed. And what they found is that you end up tearing up your cartilage and your meniscus with a sloppy, unstable knee during your youth years, and a lot of it's not repairable as you get to be done growing and get the ACL reconstruction. So techniques have been developed to respect the growth plates and reconstruct the ACL, and that's generally done by a pediatric specialist, and so we've been trained to do that.
So my assumption has always been you hear about fractures by a growth plate. You don't want that because that could maybe affect growth. So you're saying issues with ligaments and other issues like that can also affect.
So by far, growth plate fractures are more common. The growth plate we kind of talk about it as the weak link in the chain. So between bone, ligament, and cartilage, which is the growth plate is made of cartilage, it's usually the weak link. So it's going to fail first. So growth plate fractures are by far more common than things like the ACL tears in the kids that are still growing. And growth plates are sensitive. They sometimes can't take a joke, and so you have to be able to follow them and make sure they grow right and behave after they're injured. But low grade, mild growth plate injuries are very common, and usually those do not cause any long-term issue. But those are need to be managed sometimes with just a cast, and sometimes it's with a surgery to put it back together, and then follow growth.
I want to go back to the to when we were talking about overuse, because this is a huge topic of conversation, has been for a long time around sports and particularly baseball. But you said something interesting, because you said too much of something. You said throwing or tumbling, so I think of gymnastics, so it's not just baseball. But let's maybe start with throwing sports, if it's baseball, football. Do you recommend a certain amount of usage for kids? What would you tell a parent is okay or is too much?
Yeah, it's interesting. I mean, I think over the past 5-10 years, every year I give a talk to parents and coaches about youth sports, injury prevention, and wellness, and a lot of that is surrounding just the increased involvement in youth sports at an early age, and it's not all bad, but just there's certain guidelines I think that are helpful to follow to keep your little young athletes safe best you can. And it's not bulletproof, but it's good guidelines. I mean, in general, like if you just broadly look at youth sports, a lot of the challenges are when somebody chooses a single sport and does it year round. So just like you might work out and then run and then swim, you're cross training and your body likes that, but you're still, getting fit. Well, similarly, the youth body likes cross training. So instead of playing baseball 11 months out of the year, a mixture of sports would be more helpful, because you're doing different motions and activities, and so you don't have the same repetitive stress or demand on the body. So in general, we like to see 2 to 3 months off of per year of a specific sport, and that is true for any of the youth sports, gymnastics or others. And then no more hours of sport per week than the age of the child, which is commonly a broken rule. So if a 9-year-old's doing 20 hours of a sport per week, that's it's not that you're a bad child or a bad parent, but you might have some overuse issues. And look, I mean, my kids are in sports and we love it, and they love it, and we're as guilty as any in terms of certain rules broken. But that's those are guidelines that are probably smart to adhere to. The cross training, the variety we talked about, the hours participation, the months per year, 1 in 7 days off of the sport at minimum is helpful. And then there's certain warm up and cool down in certain sports that can help prevent or decrease risk of not only injury but overuse injury. And so baseball gets a lot of attention just because it is a widely participated sport here locally. But the young throwing elbow and throwing shoulder is a common thing that I see between the months of December and July because there's a lot of baseball going on.
Yeah. It's that is a giant challenge, overuse.
Yeah.
Do you like things like pitch counts and things that have been implemented into youth ball?
Pitch counts, pitch types, mechanics of throwing, all is important. So yeah, I think that's very important. A lot of the boys, and I was there once, try to throw harder all from the shoulder and the elbow, and they're not engaging the core, the hips, the gluteals, the rotation, and all the things that are important to get your power. So it puts a lot of stress on the immature elbow, the immature shoulder. So yeah, pitch counts, pitch types. Now you're seeing curveballs at age 9 and 10. That's not a good recipe for the pediatric elbow.
Why not?
It has to do with rotational torque. So if I have a ligament and muscles attached to my growth center on my inner elbow, and there's repetitive rotational torque, which has been shown to be a little bit different in the curveball than the fastball and other things, then that's a recipe for trouble. There's some that'll get away with it and don't have issue, and but you'll have some that have issue, and that can be a culprit.
At what is there a general age that you would tell a parent, a coach, a player, like this is okay to start throwing with rotational, to throw a curveball, rotational torque?
Ideally, age 13, 14. Coaches now will laugh at that because it's so widely present in 10 and beyond. And that's changed, I would say, since I even remember when I was a young pitcher, and so and a lot of this I think has to do with there's a lot of pressure on youth sports. It's become a professionalized or commodity industry where there's a lot of external stuff. There's showcases, there's tournaments outside of leagues, and there's leagues are going away, and now it's travel ball as a mainstay. And so there's some good in all that, but there's some challenges that relates to taking care of kids' overuse injuries. You're going to see more of them.
Yeah.
So if you're playing 70 games a year versus 15 league games, you're just doing a lot more of what you do.
Yeah. What do you tell parents about football? Is there's been such a noted concern from parents about whether or not they should allow their son to play football, and at what age? Mm-hmm. Do you get that question a lot from parents?
Yeah, it's another hot topic. I mean, there's been a lot of recent look at concussions as it relates to contact sports. Questions about if you have tackle football starting at 3rd grade, do they have enough mass and force to create a powerful enough hit to even concuss a small brain? And so those that are on the side of probably not enough force to do that would say, hey, it's probably just as safe as doing soccer or some other sport where you might have another type of injury. And there's been an evolution of things like lacrosse, which here locally has grown over the years, and some feel like that's, even though a contact sport, maybe a little bit less risky of concussion than football. Well, that's so yeah, I think concussion is something that gives us all pause, and I'm a parent, gives me pause about a young child taking a hit to the head and how many times can you do that. And leaves a permanent or lasting effect. I don't know the right answer to that. I'm, in kids orthopedics, I'm not really a concussion specialist, but those topics do come up,
Yeah. When we talked about prevention, we did talk about overuse. You also mentioned like warm up and cool down. Are there other things that you will tell parents or kids that are good habits or practices in the way of prevention of injuries? Not necessarily just sports related, but for any young person?
Well, I think the nutrition side is huge and probably doesn't get enough attention. And again, it's a little bit outside of my role, but I think that plays an intimate part in some of the stuff we see. Specifically, a lot of vitamin D deficiency in kids relates to a lot of the things that I treat. So, supplementing with a multivitamin that has that is helpful. The nutrition's part's big. If you think about muscles, they're attached to growing bones. And as bones grow, tight muscles can get tighter. So especially in the preteen growth spurt, you're going to have tightness of muscles that maybe you were stretching and had flexible just a month ago. And so when you're growing a few inches a year, being on a stretching and flexibility program is probably something you should make a daily routine if you're somebody that's doing a lot of activity. I think that's going to help decrease risk of overuse injury. Not prevent it, but help decrease the risk of it. So I think those are the main things. And then paying attention to the volume, frequency, intensity of the activity you do and trying to add variety where you can,
When you're in the OR, limb reconstruction is something that you do as well. My sort of novice mind would think that would be the result of some form of trauma, some real trauma. What would commonly lead to something like that being needed?
Well, yeah. So limb reconstruction is a broad topic talking about mainly legs, but sometimes arms, and how do you get a child's leg to grow like it was supposed to if something went wrong, either in development or as it relates to an injury. So imagine if you were born missing one of the bones of your leg, or imagine if when you were young and growing, you got an infection that involved one of your growth plates. Or imagine you have a tumor that involves one of your growth plates. Or the more common, imagine you fractured one of the growth plates and it was a significant fracture, required surgery, and the growth plate didn't grow right. So all of those come into the umbrella of limb reconstruction. And the question becomes, what growth plate's involved? How much growth does it contribute a year? So you can do some math, and how many years of growth does a child have remaining? And that gives you kind of a recipe for, okay, well, what kind of problem would I be looking at once they're done growing, and work backwards from there to say, how can I make a reconstruction plan now so that when they're done growing, they have a straight leg and equal leg lengths, or a straight arm and equal arm lengths. And that falls into a variety of different potential treatments. Sometimes it's just you're following it for a few years to get an idea of, okay, what's the behavior of this sick or diseased or injured growth plate? Let me see what it's going to do, and how it's going to behave. Is it going to grow slower than the other leg, or is it going to catch up? And if not, and you're going to have a sizable leg length difference or crookedness to the leg, then how do you reconstruct that? And the more recent technology, I would say over the past 10 years, that allows us to do that is all inside the bone, whereas it used to be a bunch of pins and wires and arcs outside the bone, what they call a spatial frame or external fixator, big bulky device. We still use that for a three-dimensional deformity, but for usually one or two-dimensional deformities, so if you're crooked in one plane or shortened, then we can place something inside the bone that makes your leg lengthen. And that's actually using the technology of magnets. So magnets combine inside of a rod that telescopes like a shower curtain rod. So a shower curtain rod kind of has a male and female portion and elongates. Imagine a device that you place inside a bone of your leg, The bone is a hollow cylinder. So you can place that shower curtain rod with built-in magnets inside the cylinder of the bone. You can make a controlled cut in the bone that you want to lengthen. You pass the rod across the controlled cut and hold it at the top and bottom with screws so the shower curtain rod doesn't move. And then you can trick a bone into healing at a longer length if you lengthen it about 1 millimeter per day. And that's called distraction osteogenesis. So surgically cut a bone, wait about a week, and use an external remote device that's placed on the leg that drives the internal magnet for the rod to lengthen. And they do it for 1 millimeter per day to lengthen it. So if you have a inch difference in your leg lengths, I need 25 millimeters, that's an inch. So for 25 days, you use the remote, press a button. It doesn't hurt because it's only lengthening a very small amount. Press a button on the leg for 25 days with a remote at home on the couch. And 25 days later, the leg is longer. It takes a while for that gap to then fill in because your body has to fill in that gap. It treats it like a fracture. So pretty neat technology.
Man, I'd be worried about it. I pushed that button too many times in a day. I'd be like, oh no, did we go 4 millimeters?
Your legs run off. It's programmed where it's dummy proof. You can't. We could make a Moscona programmer. You can't lengthen it too much.
I need that. Hearing you talk about that type of development and advancement in technology, you're still a young man, but you've got so much experience. You're at a point in the career where you're a very veteran doctor, but you're still very experienced and probably a ways to go. Do you get excited about what you've seen in a relatively short amount of time in pediatric orthopedics and what is still to come in developments in the field?
Yes and yes. I mean, I can't believe it's been 10 years in, and orthopedics, you're in it for probably 6 years of training and now 10 years of practice. And like you mentioned, I hope I have a long way to go. I got young kids that, I got mouths to feed. But yes.
I got kids with bones to break, so don't go anywhere.
One of the challenges in kids orthopedics, which I love but also creates a challenge, is that you're dealing with the top of the neck to the tip of the toes. And when you are taking care of kids and everything in between, you have to stay up on the literature and on the technology or it'll leave you behind. And so all the things that have been exciting over the past 10 years have been absolutely exciting, but you better keep going or else that'll be old news. And so I think that's fun, but also challenging. And looking forward, I think what I would like to see over the next 10 years, 20 years, I think is continued elevation of care for kids in the region. And that means less fragmented care. So, it's hard to hear when a parent says, oh, we go here for this, and then we got to travel there for that, and then we got to come back here for this. The Children's Hospital here has been now 4 years, and I think that has helped a lot of trying to keep care in one location for kids, especially that need multidisciplinary care. And I'd like to see that continue to grow. There are a lot of things in pediatrics that we still don't have great answers for that I would like to see improve. If you lose the blood supply to the ball and socket joint, say of the hip, there's some challenging issues we have with that we don't have great answers for, and those kids can be doomed to early arthritis in their young adult years if not appropriately caught early and treated. And even they'll sometimes we have issues. Cartilage restoration is another one. We have a hard time giving you back the cartilage God gave you if you have a big cartilage defect in one of your joints, say the knee or the ankle or the elbow. And so I'd like to see that progress. We still fuse certain joints that we wish we could preserve. Big spinal deformities require a lot of times a spinal fusion, and there's some growth in that area of research as to how do we better manage spinal deformities without having to straighten them and fuse them. Can we respect the growth? And there's some headway in that department, but we still have some to go. And so I think I definitely like what I've seen, and we have a lot of work to go. I sometimes wish I had a little bit more gray hair to give me some street credit when I talk to parents, because they kind of look at me like, okay, when's the adult, the real doctor coming in? You're the resident or the trainee. You look the age of my son. So I hope that sticks with me, the youth, but it's been fun. I really enjoy being around kids and their families.
Appreciate your hair. Trust me, appreciate the hair. Dr. Brad Culotta, it's a pleasure. Thank you for the time today.
Really enjoyed it. Thank you, Matt.